Welcome, everyone. It is 5:30, so we're going to go ahead and get started. It's good to see everyone again. We are on our second to last 50th anniversary speaker series event. Series has been fun thus far, and I know we're going to have some new faces tonight, so that's great. Just a couple housekeeping things to remind everyone to please keep yourselves muted throughout the talk, and that you can also use the chat function if you have any questions, and then I'll help moderate at the end. An email will come out sometime soon about how to claim CME for a portion of this series, so be on the lookout for that. And then I need to advance this slide. There we go. And as a reminder, our final speaker series event, scheduled on December 2nd, titled Sharing Your Sparks, will be a fun opportunity allowing participants to actually become the speakers. So please join us to share and listen to some meaningful stories and memorable relationships that have developed over time in our department. Tonight, we have an excellent talk planned with one of our very own Global Health Fellowship graduates, Dr. McDonald. So I will pass it off to you now, Dr. Best, to introduce Dr. McDonald.
Thanks so much, Nikki. I appreciate it. So as mentioned, my name's Jason Bestie, and I'm an infectious disease physician in the Division of Allergy and Infectious Disease, and also in the Department of Global Health. And on behalf of the Department of Global Health, I'd like to welcome you to a very special global health themed interdisciplinary collaboration, as this is our first joint global health speakers event of this academic year, co-hosted by the Department of Family Medicine and the Department of Global Health. And it's my absolute pleasure to be able to introduce you to our speaker tonight, Dr. Anna McDonald. Dr. McDonald is a family medicine physician who completed her undergraduate degree at Duke University and medical school at the University of North Carolina. While in medical school, she also completed an MPH in global health at Harvard, and then she moved to Seattle to do her family medicine residency at Swedish First Hill, and also was a resident at the Downtown Family Medicine Clinic. After graduating from residency, Dr. McDonald enrolled into the UW Family Medicine Global Health Fellowship, where she completed a one-year fellowship, and she also was able to spend time in Peru, earning her diploma in tropical medicine and hygiene. After fellowship, Dr. McDonald joined the Global Health Service Partnership and spent the subsequent 2.5 years living in Malawi, where she helped to develop the first family medicine program in the country. She joined the Swedish faculty in 2017 and now facilitates the bi-directional Global Health Resident Exchange Program, spending time between Seattle and Malawi. Dr. McDonald, thank you so much for taking your valuable time to speak with us tonight. We're really looking forward to your talk. With that, I'll hand it over to you.
Awesome. Thank you so much for the opportunity. And I want to start with a couple of disclosures. Number one, I'm terrible at technology. So I appreciate help from anyone in the audience if something's not going well. And second, I have a dog who may jump in because she feels the need to say hi at all times. So if you see her in the background, she is part of my Malawi experience, and it's therefore appropriate that she's joining us today. So with that being said, I'm going to attempt to share my screen. Can you guys all see that? Awesome. Okay, so thanks again for the opportunity. This talk is called Go Fast or Go Far, Building Better Partnerships in Global Health. So there's a lot of things I could talk to you about. I've been engaged in this work for 6 years now, and figuring out how to compress 6 years of mistakes and lessons learned into 45 minutes is always a challenge, but I'll try my best. So just to lay some objectives, we're going to review sort of a brief history of global health and some of the problems that are inherent in the traditional approach to global health programming and partnerships. And then I'm going to talk about family medicine in Malawi and what my role in that process has been, with a focus on the resident exchange program that I now facilitate between Malawi and many of the wonderful residents in the WAMI network. And I'm going to close with some lessons learned about how to develop more equitable exchange programs. And please feel free to interrupt me with questions. I'm not monitoring the chat, but I think Nikki is and will alert me if anything pops up. I also hope to leave time for questions at the end and encourage any questions and/or perspectives, as I imagine a lot of you have experience in this type of work. So why am I here? Ultimately, I love this photo for two reasons. Number one is a medical education person. It is a little boy who is learning to fish. He is not being taught, he's learning himself. But the second is that this phrase Mwaiwala in Chichewa means have you forgotten? And that phrase has a lot of meaning to me. When I first got to Malawi, I thought a lot about sort of inequity and privilege, and did a lot of sort of unlearning of things that I had learned in my career prior about knowledge and power. And, you know, it was a grieving process. And the longer I'm there, the more I question this, because though my work is technically in global health and partnership development, it often feels like this question becomes more and more important, thinking about partnerships and who's forgotten in those partnerships and who are they built for. So I just want you all to take a minute to sort of think about the answers to these questions. If you want to throw something in the chat, by all means, do so. But the first question is, how do you define partnership? And I'll just pause for a few seconds because I'm not sure I'll get through all the content if I really give us a lot of time to think about it. So the second question would be, how do you define an equitable partnership? And the third question is, does this change when you apply the term global health? So I love this quote: global health is a Northern concept. For the academic institutions in Global South, everyday public health, medical and nursing education and practices constitute global health. So this really is sort of a question about what it is that we all work towards. So, you know, global health as a field was born out of tropical medicine, and that was a field that was started with good intentions, where people from historically well-resourced contexts would go to lesser resource contexts and research diseases that they didn't have in their own places. And again, these were often done with the best of intentions, but there are very colonialist roots inherent in that model, and we need to acknowledge that. You know, we've created a field for what many people in the world just practice as medicine and public health every day. But we as the Global North have come over and said, no, this is global health, and inserted ourselves into that practice. So I want to acknowledge that. And if you're not familiar with Madhu Pai, prolific writer about global health and power and privilege, and I just really, really love this illustration because I think it captures it so well. The elephant in the room in global health is always power and privilege. And I think it's even more striking to consider this diagram and all the pieces that go into it. But if you think about each one of these people representing, you know, different structural issues that lead to power and privilege, if you picture them as not having ever seen an elephant before, they're feeling around, trying to describe it and not seeing the full picture. And this, I have never found a more real representation of what it feels like to do global health work within a community that doesn't have power and privilege. So the good news is, you know, there's more and more sort of discussion in academic forums about partnerships in global health, and there's more recognition about the inherent inequity that exists. I think oftentimes the burden of these partnerships are placed on our low and middle income country partners, and that comes, you know, in different forms, whether it's providing the human resources to do the work, whether it's the time that's required for them to be involved or participate, often uncompensated. And the fact that they're often asked to provide cultural and language orientation, again, without compensation. While the benefits of these partnerships tend to fall to their high income country partners, that's paper authorship, conference attendance, presentations, funding for research. And I would argue even like who gets to ask the questions that are researched, so that often comes from the high income country partners. And again, another just really striking image that I think about frequently to sort of give an example. You know, there was a study done in 2012 looking at all of the publications that came out of Burkina Faso, and 95% of those papers were authored, had a first author who was from the global north. So, raises the questions of, again, who's asking the questions, who's setting priorities for research, and who's benefiting from that partnership. And another study, similar findings, looking at all university global health programs, found that 87% of the authors, just like total authors, not even first author, 87% of them came from North America. So is partnership really the right term to use when we're discussing this type of work? And as always, I think it's really important to center voices from our partner countries. And so, they often say things so much more eloquently than I can. So I'm just going to read you from a paper by Kalinga, who's a Ugandan researcher, who said, "Why don't more African researchers speak up? Many do, but the real question is, why won't Western institutions or funders listen to us? My experience shows that junior Indigenous staff are routinely disregarded. Senior academics on the project will instead turn to other prominent European experts, many of whom have hardly visited the country of their expertise. The very foundation of these partnerships reinforces the power of those who bring the funding." And similarly, I really liked this quote that's on the right, which actually, I'm not sure, there we go. I couldn't see it because of the panelists, but the gist is that we often refer to our partners as underrepresented, when in truth, they're not underrepresented, they're underconsidered. Like, there is tons of writing out there, but does it make it into the big publications? Oops. So with that sort of contextual background in mind, I want to talk specifically about my work that I've done in Malawi. And, it is work that is done by a team. This work has been the greatest privilege of my life. It's also been the hardest and best thing I've ever done. So I am by no means an expert in global health. In fact, I've probably made every mistake that you could ever make in this type of work, but if we can't talk about mistakes, we can't learn from them. And I think it's really important to do so. And I also want to say that, like, if this feels like a challenge or an assault to the work that you do or work that you do in service, that is not my intent. But I do think that we have to acknowledge sort of the privilege and power that we bring into these situations so that we can critically evaluate them and work towards better partnerships in the future. So with that being said, I'm going to talk about just briefly the sort of work of the family medicine department in Malawi and how I have been a part of that work. I imagine that most of you have not spent any time in Malawi. So just briefly to orient you, it's a small landlocked country in sub-Saharan Africa, about 18 million people there. About 80% of the population lives rurally. 70% lives on less than $1 a day. So adversity is the norm. And from that adversity comes an extreme resilience and unfortunately also an extreme vulnerability, especially when you think about healthcare and healthcare as we know it from our own cultural lens. And again, I don't mean to say we as in we've all had the same experience, but I think many of us have trained or worked predominantly in this country, so have a different sort of expectation of what healthcare is meant to look like. So healthcare in Malawi is incredibly challenging. There's a really high burden of disease, lots of TB, HIV, and malaria, lots of malnutrition. There's a low life expectancy, a high birth rate. It's incredibly difficult for people to access services. And, those things get more and more, those challenges get more and more amplified the further away from the big cities or the central academic institutions that you go. Just as one example, that I think helps ground my own reflections about this, in 4 years of clinical training in the US, I experienced one pediatric death during my peds rotation intern year. In my first 2 hours in Malawi, where I worked predominantly in the pediatrics ward because that's where I was asked to go, I watched 3 kids like take their final breath. So the disparities between the experience on this side of the world and the experience on that side of the world are just immense. And that brings a lot of challenges to this type of work. And I think, you know, I'm not going to belabor this point because it's pretty obvious, but some of the main clinical challenges that come up are first and foremost patient volume. So Mangochi District Hospital, where I work, serves a catchment area of about 1.5 million people. The average clinician there will see somewhere between.
¿Qué quieres cenar?
Oops. Somebody is unmuted. I don't know how to do that. Anyway, so the average clinician will see somewhere between 250 to 300 patients a day. If you do the math, that's about 2 minutes or less per patient. So it's hard to even think how you can do any care that mirrors what we're used to in that amount of time. So this is a picture just outside of the maternal child health building. And that is like what I would walk out of my house every morning, and I'd have to pass through this to get to the hospital. So, you know, it already feels overwhelming just optically, just seeing all the patients there waiting to be seen. And despite, you know, the incredible number of patients that are seen, still not all of them are seen every day. The second is just general infrastructure. Quite different. I think part of this is the legacy of lots of NGOs not willing to or not prioritizing investment in brick and mortar structures because of historical concerns about corruption. But if you are working in a physical place that can't meet the needs of the people you're trying to serve, that's a really big challenge. And I just put this picture there because this is the accident and emergency, or the casualty room, the entrance point for the hospital, again, for 1.5 million people. It has since been renovated, but the first 2 years I was working there, this is what it looked like. And behind that black curtain, you would find the patient bed and then this trolley. And that was what was available to deal with any and all traumas that came through the door, and not just traumas, emergencies. So that could be an eclamptic seizing mother, that could be a crocodile bite, that could be just any and everything that you could imagine. And on the topic of limited resources, you know, you have to mention medications and diagnostic resources. So by comparison, this is the picture on the left is the drug cabinet on the pediatrics ward where I work, in the high dependency unit, or which is the closest thing we have to an ICU. And on the right, that is just the selection of NSAIDs in, you know, a pharmacy, which is probably much more familiar to you. Again, to give some context, there was a period of 3 months my first year in Malawi where the only antibiotic we had in the hospital was penicillin. So unless you had syphilis, it didn't do a whole lot. And we, you know, experienced a lot of death during that time. Similarly, I can remember a meeting in my first year there where our district health officer, Dr. William Penno, called a meeting of all staff, like all nurses, all clinical officers, all community health workers, and we had to make a decision as a group as to whether we were going to buy soap so that people could wash their hands, or paper so that we could write notes for the patients that we were seeing. So resources are extremely limited, and that goes, you know, even to things like power and running water, which are not guaranteed. But perhaps more importantly is the human workforce, or human resources for health. If you've never had a chance to play around with the World Mapper website, I love it. You can pick a variable and then they scale countries to size based on what's available in different countries. So this one is physicians working. And if you're more of a numbers person, I'm just gonna tell you that Malawi has 1.8 physicians working per 100,000 population. That probably doesn't mean a whole lot, but comparatively, the US has 255 per 100,000 population, and the WHO says that, you know, at the lowest level, you should have 230 per 100,000. So Malawi has less than 1% of what it needs to meet the demands of its population. I think another piece that like is often left out when you talk about healthcare systems is the clinical teaching environment. I imagine many of you are educators yourselves. And so it's just worth noting how challenging it is to teach in this context. If human resources are short for healthcare delivery, they're even shorter for medical education. So it's hard to build a workforce without teachers. And all of the other sort of resource limitations apply as well. So physical space is tight. Sometimes you give lectures to a classroom full of 200 students, depending on what type of student they are. You may not have a way to amplify your voice even, so difficult to teach in that context. Similarly, as COVID was unfolding and lots of partners were interested in helping develop capacity for teaching, like asynchronous learning platforms that were reliant on technology, I think it's a good reminder that less than 30% of the medical students in Malawi have access to a personal computer, let alone a power source and or you know, access to internet. So those things all make our job as educators really difficult. You can see this as one student trying to show some chest x-ray findings to a room full of people, most of whom are not even able to fit in the physical space, so they're standing out in the hallway. And with all that being said, I want to take a quick pause because what I've just done is sort of describe a lack of a lot of things. And a couple weeks ago, the AAFP held their Global Health Summit, which they host every year. And there was an amazing talk by Dr. Shaili Prasad. And he talked about Global Health 1.0, which was that original version I talked about with like tropical medicine, people going over to research. And then Global Health 2.0, which sort of was more intentional. It was looking at where are the needs and how can I fix them or we fix them. And his big message, or what I took from his talk, is the need to move to Global Health 3.0. And that is a focus on, rather than needs-based approach to development and health, an assets-based approach to development and health. And I think it's really important to reframe the way we've thought about this, because what we've been doing so far just hasn't worked. I mean, yes, there are successes, but again, I would ask you to critically evaluate what those successes look like, who's telling this story, and where is the success, like who gets the credit for the success. So just to like make it a little bit more tangible, I think some of the points that compare the two that are most useful for me is to move from a frame of thinking as like a community is something that needs to have something done to it, to helping a community take control and take action. And rather than fixing things, we're going to support people to develop their own potential. And it's like a perfect approach for family doctors, because this is what we do every day with our individual patients. I think, you know, there's a lot of understanding that care should be patient-centered, and like we're there to uplift and support, not necessarily like do things. And so it's just really nice to know that all of you know this and all of you have the ability to do this because you're already doing this every day. It's just a transition in thought from this is a patient sitting in front of me to this is a community that I want to support. So Malawians knew this a long time ago. And while the history of family medicine is relatively short, you know, much shorter than UW's history, they prioritized family medicine early because I think they thought a lot about how do we reach these people in communities that are way far away from central level. So, you know, in 1991, the College of Medicine was formed. It's a young institution. Prior to that, all of the physicians working in Malawi were trained externally and then came back to practice if they came back at all. And then in 2011, the Department of Family Medicine was formed. One interesting thing to note is that it's the only clinical department that is under the School of Public Health rather than the School of Medicine, where all other clinical specialties live. And I think, again, that just gives a unique viewpoint and approach to patient care, because it's really about meeting patients where they are in their own communities. And in that same year, 2011, the first medical student clerkship began. Medical school in Malawi is 5 years. The family medicine is the only clerkship in the entire 5-year course that students spend outside of the central hospitals in the main cities. And they spend 4 weeks working in district hospitals during that rotation. And then in 2015, the first class of postgraduate trainees, or what we would call residents, started. And again, that's a 4-year program. And it has a lot of unique aspects, one of which is the fact that it's the only postgraduate training program that's based in the district hospital context. And I think it's really important to remember, again, that 80% of Malawi's population lives rurally, but our trainees are the only ones who work in rural settings. And so, yeah, you know, less than 5% of Malawi's population will ever set foot in a central hospital. So it really is a nod to trying to get care closer to people and where they live. And then in 2019, the first cohort of trainees graduated, which was a huge success. And I could talk at length about any aspect of those programs, whether it was like how and why we train medical students, how and why we're in the districts, how and why we train residents or postgraduate trainees, but I think most applicable to probably most of you is the resident exchange program. So I just want to briefly acknowledge that history as well. And it was born out of a program called the Global Health Service Partnership, which is a partnership between the Peace Corps and Seed Global Health. And in 2014, Dr. Elizabeth Hutchinson, who I believe is on here, piloted this academic partnership in Malawi. So it was really her vision, along with her colleagues at Seed and Dr. Martha Makwero, who was the head of our department at the time. And they thought, you know, can we use resident physicians as physician extenders, and is there capacity to grow and expand sort of our ability as educators through the use of residents? And then in 2015, the first WWAMI residents came to Mangochi District Hospital. They had, residents had come prior to work with Dr. Hutchinson. They were not in the districts yet because the program was still growing there. So in 2015 was the first time they came to Mangochi specifically, and pictured there on the right, you'll see Dr. Alicia Ashby, who came over for a rotation alongside 2 of my Malawian colleagues, Emmanuel Nkolokosa and Harvey Lakapa. And then in 2017, we felt very strongly that bidirectionality of the exchange program was super important. So we brought the first cohort of Malawian trainees to Seattle for a 6-week rotation in 2017. Like all partnerships, there's a lot of moving pieces and a lot of players, and I just want to acknowledge all of the different pieces that go into it and all the different people we work with. Kamuzu University of Health Sciences is the new name for the College of Medicine. It was just renamed, I believe, 2 months ago. Global Health I already mentioned, and the WWAMI Network, as well as Providence St. Joseph Health, who has provided ongoing financial support for the exchange program. But, you know, with all organizations, there's a lot of turnover, and I think that's especially true in global health work, where things are constantly changing. And so in order to keep these partnerships functional and equitable and centered on local communities, we really have to have ethics at the center of everything we do. Again, this could be another entire talk. I'm not going to go into details, but it's an article that I want, you know, people who are interested in this type of work or participating in this type of work to know about. And this was the DeCamp article in 2018 that was published in the Annals of Internal Medicine. And basically, it was sort of an ethical guideline for how to approach short-term experiences in global health, but I would argue that they apply to any experiences in global health, and they outline sort of 6 principles that we've really tried to incorporate into our collaboratory experience from the beginning. And so, with those things in mind, some of the components of our exchange program that came out of this are, number one, that the exchange be bidirectional, and I've already talked about that, so I won't go into details. But a second is that there's a focus on equity and cross-cultural collaboration and learning. Just, emphasizing that everybody has different experience and everyone's experience is valuable. And we do a lot of orientation with our residents in the US before they go to Malawi about what cross-cultural communication is like. And similar, when the Malawians come to Seattle, we spend time orienting them to our culture and what to expect. Another big tenet for us is sort of protection of host country national resources, both human and material. So we never send learners to Malawi when either myself or Jacob Nettleton, another UW grad, is not present, because otherwise the burden for sort of orienting them and teaching them and spending time with them falls on our host country partners, and it's really unfair. So we try and offload them by being the go-to person and the cultural in-between or bridge voice for residents who come over. Similarly, material resources are always a touchy subject. There's no shortage of fascinating clinical cases that happen in Malawi, and American residents who come over really want to experience that. They want to go into the theater and watch whatever, the uterine rupture. They want to see the complete ectopic pregnancy that made it to term and just go into the OR and see that. And we have to constantly remind them, supplies are limited. If you scrub into that case, that means a Malawian learner is not going to scrub into that case. And it means, and they're the ones who are going to inherit this health system. So you should never, when resources are that finite, you participating means you are effectively taking a learning opportunity away from someone else. So by all means, go and watch, stand, far away, don't scrub in, but don't scrub in. And that's just, one example of how the presence of a person who can do that sort of bridge advocacy between the two sites is super important in this type of work. The goals of the exchange program for the US residents who visit Malawi is to offer clinical support for medical and clinical officer students. Initially, we had wanted to do a lot more resident to resident teaching, and there is some room for that, but their experiences are so different that we found that it's a lot more useful to pair the US residents with medical students and clinical officer students, again, because they haven't had a lot of one-on-one training. They can do some basic education around physical exam or basic skills like suture, knot tying or POCUS or whatever it is. They also are really instrumental in modeling family medicine principles. So remembering that family medicine is a new concept. So things that seem simple to us or routine, like routine follow-up, making a safety plan if your patient decompensates or gets worse. Those types of things are new concepts, and the US residents are really instrumental in sort of reinforcing that and the importance of that. As always, we tell them their main focus should be to build relationships and just to learn and understand and observe, to share their values and to make lasting friendships with the people they're learning from. And then also we try and model multidisciplinary approach to patient care, because that is something that is not historically taught or encouraged in Malawi, which is a very hierarchical culture. So oftentimes nurses and doctors don't talk. There's a pretty difficult working relationship, or there can be a difficult working relationship there. So just encouraging that communication and bringing multiple players to the team. And then more recently, we've had them support student QI projects, because all of the medical students who come through do a QI project. And so because the residents are also learning QI. It's an area where they can support each other and learn from each other. The goals of the exchange for the Malawian registrars when they come to the US is number one, just to have exposure to clinical medicine in a different context. You know, remembering that primary care is not really something that exists outside of HIV medicine in Malawi yet, though it is growing, especially with the influx of non-communicable diseases like diabetes and hypertension. So it's a chance to see what outpatient medicine really looks like. And we asked them to define their learning needs, which every group so far has identified both adolescent and geriatric medicine as priority areas because they don't get a lot of teaching of that. They also are able to participate in the UW Global Health Leadership course, and they present at the AAFP Global Health Summit. And again, the idea is just getting them some leadership and public speaking experience and presentations for their resume. And last but not least, I think academic development, I really can't understate the importance or overstate the importance of that. These three humans pictured here are our first cohort. So Nita Nayeja, Jesse Mbamba, and Modai Nanula. And all three of them now have graduated and have leadership roles within the department. And prior to this, you know, the family medicine department had one person on staff who was fully Malawian. And so now we have 4. So, you know, that is just so important because they are going to become the teachers and stewards of family medicine moving forward. So quick summary of the partnership to date, and these stats are all pre-COVID because everything's been shut down for way longer than I would have liked it to be, but we've had more than 50 US residents come and work in Malawi, and we've had 2 cohorts of Malawian residents come to the US. The third was actually scheduled to be here now, but because the US embassy was closed, they were unable to get visas, so that's on hold until next year. We've had a lot of successes, and I think sort of the 3 that are most prominent in my mind are, number one, the recruitment of other longer term faculty for global health work. And, you know, again, just endless appreciation for Jacob, who helps me co-run this program and spent 2 years, came over as a resident, did the program, and then spent 2 years full-time in Malawi, which allowed me to start doing the back and forth. And now he and I kind of switched places. And then Elise and Janelle, who are both Swedish grads, who also each went and spent a year in Tanzania. And Janelle is working to develop global health programming at Rutgers now. There's a lot of other people that I could mention, but just want to mention those 3. And then the second is the development of the Malawian family medicine leaders who I just mentioned. You know, if the goal is to make yourself obsolete, which I would argue it should be, that is the most, you know, having your former students come on and take leadership roles is the best way to do that. And then third is the continued relationships that I've observed on both sides. You know, every time I go to Malawi, clinical officers and former students ask me about how various US residents who were there during the time they were in Mangochi are doing. And similarly, the US residents who have been to Malawi frequently ask me what's happening on the other side of the world, or they'll say, oh, you know, I was texting with so-and-so. So those relationships are really important and long lasting. So that's where we are now. Where are we going? I think a lot of you have probably seen this diagram. I recently saw a newer version of this diagram that I really liked. And that was to acknowledge that the reality is neither equality nor equity, that it's incredibly there's a lot of differential in how we access and view the world. But my favorite part was this, and the goal should be this 4th picture, which is liberation or removal of the fence in general. And again, because local voices are so much more powerful than my own, I want to read this quote that says by Lilla Watson, who's an Indigenous Australian activist, and she said, "If you are here to help me, you are wasting your time. But if you have come because your liberation is bound up with mine, then let us work together." So working together, a lot of people with a lot more experience than me, who have done a lot more thinking about this than me, recently proposed this brochure declaration, or what I would call, an extension of Global Health 3.0. So what they say is, we recognize that global health as a field of practice should aim to reduce disparities in health and well-being around the world. The ethical framework that underlies global engagement is based on principles of mutual respect, solidarity, and social justice. Communities' needs should be the most critical driver of these activities and should be set by members of the communities themselves in conjunction with the health priorities of the country. And that global health engagement should be sustainable, assets-based, bi-directional, adhere to appropriate legal standards, and be adequately evaluated. Oops. There are 6 core principles. I'm just going to read them briefly. I wish I had a lot longer to talk more in depth about them, but just so you've heard them once. Number 1 is mutual partnership with bidirectional input and learning. Number 2 is empowered host country and community defined needs and activities. Number 3, sustainable programs and capacity building. Number 4, compliance with applicable laws, ethical standards, and code of conduct. Number 5, humility, cultural sensitivity, and respect for all involved. Number 6, accountability for all actions. So are we there yet? No. Can we get there? I think so. And, again, I'm going to use those 6 principles to just give you sort of 6 lessons that I've learned. There are way more than that, but time will not allow me, unfortunately, to go into all of those. Fortunately for you. The first and most important lesson, I think, is to invest in people and not programs. When you invest in programs tend to be vertical in their thinking. And I'll just give you one quick example, that there is a lot of congenitally acquired hepatitis B in Malawi, and a lot of people die of, HCC cirrhosis. And many of them are Hep B positive. Whether or not that's the ultimate cause of their demise, it's hard to say, but there's no treatment available. And that's because all antiretrovirals in the country are funded and purchased by HIV programs. So if you are HIV negative and hepatitis B positive, there's literally no way to get treatment for you unless you become HIV positive. So moving from that approach to funding programs and investing in people who work in these communities and would be able to know and sense that and have a true full picture of what's going on is the most important way you can have sort of impactful work, I think. And I just put these 2 pictures here because the picture on the left is from my first year in Malawi. I had never learned POCUS in my own training, but this is, again, Emmanuel Nkolokosa, who is now the head of the pediatrics department. And he and I literally learned it together. We would on weekends watch videos, practice together. And it was really important to me. He is one of the best clinicians I've ever known. It was really important to me that he had access to the ultrasound at all times. And I went back into the wards like 2 or 3 years ago and just saw him teaching to other people. So as educators, our impact is multiplied when we invest in people and give them the skills that they can go and teach others. Lesson 2 is to center local voices, or to lead from behind. And what am I talking about there? I'm really talking about empowerment and access to a seat at the table. This is a group of medical students who come through the district, and one of the lectures that we had always given was about how care in the district level context is really different from central level. And we finally, through relationship building and time, the district medical officer there in the blue shirt, Dr. James Kumwenda, finally, knew enough about us and said, you know what, I'd really like to teach that. And it's so much more powerful for the students to hear from someone who understands their culture and background and context than it is to hear from me. And it's not that I didn't have a role in this anymore, but like my role was to find the room, create the space, and facilitate the conversation, not to be leading the conversation. And so like every time I'm able to do this, it feels like a huge success. Lesson 3 is relentless incrementalism, which is a term one of my friends uses, and I love it. And to quote one of my teachers, Dr. Carol Heyman, don't just do something, stand there. And when you're talking about global health, it's standing there for a really, really long time. Things move at a different pace. Solidarity is not a one-time event, it's a lifelong endeavor. And if you're really invested in these communities, you need to be present for a long period of time. I put these pictures up because on the left, you'll see Dr. Jessie Mbamba in the white sweater. She's now our postgraduate coordinator and organizes the entire sort of postgraduate training program. And on the right, you see Dr. Modai Nanula in the jeans, who is handing over some drills to one of our orthopedic clinical officers who helped facilitate and run the orthopedic module for our residents in the district when we were unable to get them to the central level. So, you know, watching them grow in time is and take over, you know, again, the goal being to make yourself obsolete. Lesson 4 is to acknowledge your inner Ted Lasso, and full disclosure, I've never seen the show, so I may be royally butchering it, but I think the general premise is he was an American football coach and is taken to the UK to run a British football, aka soccer club. So, you know, context is so hugely important to this work. And while you may be a physician with a lot of skills, those skills don't necessarily translate to a different context. And, you know, again, because they always say it better than I do. And if you don't follow them already, I would encourage you, oh no, it didn't show up, to follow an account on Instagram called No White Saviors. And they make this point much better with a single diagram, which I thought would show up, but it's apparently not in the slides. And it just says, expat does not equal expert. Your whiteness should never be a tool for access. And we talk a lot with the residents, the US residents going over to Malawi to say, you know, I want you to stop for a minute anytime you're about to touch a patient and turn the tables. Like if a Malawian physician walked into a US hospital where they're not credentialed and not trained, and they wouldn't be allowed to do the thing that you're about to do, don't do that thing. So yes, we all have skills, but we need to acknowledge how and when we can apply them. Lesson 5 is just general gratitude and humility. I could talk for hours about this. I won't. I will leave you with one of my favorite quotes of all time by Arundhati Roy, who said, to love, to be loved, to never forget your own insignificance, to never get used to the unspeakable violence and the vulgar disparity of life around you, to seek joy in the saddest places, to pursue beauty to its lair, to never simplify what is complicated or complicate what is simple, to respect strength, never power, above all to watch, to try and understand, to never look away, and never, never to forget. And my last lesson is the most difficult one, and that's accountability. And again, from No White Saviors, COVID was the biggest and most egregious example of accountability that I've seen in my short career in global health. And I think about this quote all the time. They said, how necessary is an organization if it can close up shop and evacuate every single volunteer as soon as shit hits the fan? Pay attention to what COVID-19 is telling us about development and foreign aid. Y'all are quick to leave communities that are not your own. And again, if you have 5 minutes on a commute anywhere, I would highly encourage you to read this article that's there on the left. It's short, it's a quick read, and it's incredibly powerful, written by 3 Ugandan physicians. And I just took the quote that was most powerful to me. Like soldiers on a battlefield confronting a foe that threatened populations everywhere, we assume that combatants and commanders alike would not retreat or surrender in the face of danger. But despite years of consensus around the need to stand with populations in materially impoverished settings, the known consequences of Uganda's health worker shortages, and the urgency of preparing for the pandemic, our international collaborators were suddenly acting like the idea that their staff would stay in Uganda was absurd. From our experiences during Ebola epidemics, we fully understand the fear of working during a disease outbreak, including how challenging it can be to be separated from loved ones in such moments. At the same time, the isolation through which we've endured COVID-19 underscores a reality that Uganda and other countries in Africa have known for a long time. Equity in global health partnerships almost always feels like a moving target. So a few take-home points, I think the longer I'm in this work, the more I challenge myself and others, and I have a community of people who have been engaged in this work, similar work to what I do for a long time, and we try to hold each other accountable to this, and that's to evaluate your why. Like, why are you doing this work? Is it about you? Is it about communities? Are you the hero of the story? And the second is to just know your context. Context is 90% of the game, and we know that systems create what they're designed to create, and we have an inequitable system, and thus inequity in global health persists. And last but not least, to know where your strengths and limitations are, as well as those of your community and teammates, so that you can sort of maximize impact. Oh, sorry. And last, one more, to know your resources, to recognize the power of your own privilege, and how you use that power, whether it's to elevate voices or to be a bridge voice. Sometimes that means elevating your own voice, which for some people, myself included, is incredibly uncomfortable, but that is something that I need to do. So with all of that said, I want to make sure I leave time for questions or discussions, and I want to hear any experiences that others are willing to share. And just to say thank you, Zikomo and Chichewa, to my colleagues on both sides of the world who continue to push me in all directions to be a better clinician and human, and to the students who just make all the work worthwhile. And with that, I think I will close and stop sharing my screen if I can figure out how to do that. There we go. All right. And I'd like to open for questions or comments or thoughts or other experiences that people have had.
Dr. McDonald, I just want to thank you so much for this talk. It was just so engaging, and I know the speaker series and the entire 50th anniversary committee in our department is so thankful for you sharing your experiences and talking about this very important topic with an equity lens, and it's so important, the work that you're doing. So thank you for all that you do. I know Lynn wanted to say something, so I'm gonna let her talk. Go ahead, Lynn.
Yeah, so I just wanted to say in 2015, Anna and I got on an airplane together and flew to Lima when Anna was a global health fellow, and where we did our diplomas in tropical medicine and hygiene. And Anna, I just want to say thank you. You and I talked and raged and, had more than one glass of wine probably, piscos together, raging and talking about a lot of these issues. But I'm just so impressed with how you actually lived it and have lived it. And I think that this is actually one of the best talks I've ever heard. Pretty much in anything, actually. Just spoke to me a lot about some really, really important things. And we see a lot of students. I've had a lot of personal experiences with different groups in other countries that basically violate every single one of these principles that you have outlined so beautifully. And so I just want to thank you for sharing your experiences and teaching us.
Thank you, Lynn, and thank you, Nikki. Lynn, you are an essential part of my journey, and so thank you for, giving me fuel for the fire.
I see a couple people with their hand up, and then there is a question in the chat. We'll start with Judith, and then we'll go to Matthew, and then the question in the chat.
Actually, I think Matt had his hand up before I did. So
He did, but he passed it to you. So you're
oh
up
my
first.
goodness. Uh-oh. Well, first of all, Anna, that was fabulous. It was really insightful and very moving, and it was a privilege listening to you talk.
Thank you.
So that's number one. My question may sound like an odd one coming from somebody who's based in global health, but it is how you think about the lessons and the principles that you covered in terms of our marginalized communities and low and middle income countries right here in the United States. When I spent several years in Bangladesh, and one of the things and then I came back to Baltimore. I was at Hopkins for a while, and I have to tell you, one of the things that really struck me was how similar some of the issues were. And so I'm interested in how you think about this in terms of your work here domestically as well, because I think this bidirectionality really pertains if we're going to change things here.
Yeah, thanks. It's a really good question and one I think about frequently. And I guess the easiest or the quickest thing that comes to mind is just to go through your own process of unlearning. Like, I think so much of medical school and medical education is focused on having the right answer. And I never walk into a patient encounter anymore thinking I have the right answer. Always trying to put that person in front of me, front and center, like, what can I do for you? What is bothering you? Like, is this important to you? And I think, unfortunately, so much of the way we teach medicine and we practice, especially when you're new in your career or you're just learning, is like asserting yourself. And that's just never a good partnership. So I guess having contextual experience where everything is upside down and literally having to learn to live in a culture where, like, you don't know anything and everything that you think is true is not true for the rest of the people there, is a continuous exercise in humility on all fronts. And I think Joe Bruner put something in the chat about humility. And if there's just like one word or one thing I think about, it's to approach sort of every interaction with that. Like, I'm not an expert. One of my colleagues in Malawi, Dr. Lutala, who is a continual mentor of mine, just says, in every encounter, there are two experts. There's the doctor and the patient who lives their life. And so, in general terms, I think sort of acknowledging what you do know and what you can bring to the table may not meet what a patient needs or feels, or a community needs or feels is important to them. So that's step one.
Yeah, I think it's sometimes harder to remember that when we're here at home in our own country for many people.
Yeah, for sure. And, living between two worlds is incredibly challenging for a lot of reasons, but it's also a constant reminder of that for me. So I'm grateful for that continuous learning opportunity.
Matthew, your
Hey,
turn.
Anna. Thanks so much.
Dr. Thompson. Yeah.
Hey, thanks so much for that presentation, Anna. It's so good. I think the last time I saw you was in Malawi, and I'm not name dropping here, but it was very good to visit with you and the family medicine team there. So I've got a question for you. It's clear to many of us, maybe all of us on this call, that the overwhelming evidence is for a primary healthcare based approach to improve health, both in high income countries as well as low income countries, middle income countries. Yet it's also transparently clear that the major funders in the United States, including foundations, well-known local foundations, NIH and others, have, let's say, obliterated that approach. What impact have you seen in Malawi from that top-down, silo-based, disease-based approach that I sense has perhaps harmed care in many ways rather than helped? But what's been your experience on the ground in Malawi?
Yeah, great question. I mean, I think it has 100% impacted care. One of the most impactful talks that I've ever heard was by Yanni Hugo, who is a primary care researcher in South Africa. And it was a one-slide talk, and he spent the entire talk, and it was a picture of a soccer team. And he built the entire talk around the idea that we've built a health system of only goalies, and like diseases and social determinants and all of these things have a continual offensive attack. But if we are putting all of our money and investment in hospital-based care, tertiary care, subspecialized care, that we have lost the game before we've even started playing. So, if you are not familiar with his writing, which I wasn't previously, that's a good place to start. And, it affects everything that we do, these vertical programs. Another example I can give you, we couldn't do any blood donation. So anemia, I would say, is the leading final common pathway to death in Malawi, at least in Mangochi, whether that's postpartum hemorrhage, that's pediatric anemia with malaria. But there was a period of time where we couldn't do any blood transfusion because we didn't have syphilis testing kits. There were tons of syphilis testing kits in the hospital, but they were purchased by one of the family planning organizations. And so we couldn't use them. So all these people died because we couldn't test blood to make sure it was safe, which is important, but it's just this broken system. And, people like the district medical officers, district health officers who are physicians who finish their training and go straight into administrative roles have much more eloquent and more sort of comprehensive views of how this plays out on the day-to-day. I can't remember if you met Dr. William Pino when you were there, but he was the district health officer for a while, and he had this metaphor that I think about all the time. And he said, running a health system in Malawi is like having a new house, and someone comes over and they say, "Oh, you got a new house, that's so great, here's a couch." And you say, "Oh, thank you for that couch." And then your next friend comes over and says, "Oh, you got a new house, that's so great, here's a couch." And he expressed it of being like, "Well, I don't need a couch, what I need is a refrigerator, because I already have a couch." And you can say that to the person, they say, "Great, here's your couch." And that's repeated over and over again until you end up with 20 couches and not a functional space to live. And I think that's so much of how global health runs and operates in the current model. So again, like everyone's looking at it from what's needed, and they have their own ideas of what's needed rather than what does the community want or prioritize or say that they need. So the more you can approach the work without an agenda of your own, the more likely you are to have success, and just say, "Hey, what do you need? Like, how can I come in?"
Thank you.
Yeah. Thanks for the question.
I do want to acknowledge that it's after 6:30, so anybody who needs to leave, please feel free to do so. I did want to mention that Dr. Phillips put something in the chat about how you can contribute to helping investigators and authors from nations underrepresented in academic research and publication. He has a website there, and it's for a global network of researchers helping each other advance their work. So thank you, Dr. Phillips, for posting that. And then last question from Richard Bruner. He says, "That was fabulous, Anna. Thank you for your work. It sounds like it takes a lot of humility. Any tips?" It's a great question.
Yeah, tips for humility, I don't know other than to acknowledge that, continuously acknowledge that you don't have all the right answers, and that's okay, and to encourage like group thought and group perspective. And you know, I practice humility every day, whether intentional or not, in teaching residents on both sides of the world. Like, great question, I don't know the answer, let's think about it together. Here's what I do know. What do you know? What, you know, help me think about this problem together. And Joe, having had the privilege to learn from and work with you for a long time, I know that you know these things. So I would ask you the same question. Yeah, just removing yourself from being the center of the story, and trying to acknowledge all the wisdom and knowledge that is out there that you don't have, but also while also acknowledging that you do have something of value to add.
Thank you, Anna.
Thank you. I will say too, just a quick idea about research, and sorry, you know, totally feel free to go. Thank you so much for sharing that author aid. Another, you know, dream project that I have, if I had $1 million, would be to have a pot of funds where Malawian-led researchers could apply for grants. And again, like, I don't want to be the one who determines what's considered and what's awarded grant money to, but to facilitate the funding, because lots of people want to give money and they're like, well, how do we do this? But to have a pot of money that then, like, the challenge is convincing the donors to let go of any control, because, you know, what is that about? Are you giving money to help a program, or are you giving money to say, I did this thing? And if you critically evaluate that, if we want to let programs develop and grow and support from communities, then we need to give them the power to make those decisions.
Thank you so much again, Anna, for your great answers to these questions and your talk. It was just so engaging. We all very much appreciate it, and it's been a pleasure. I will go ahead and close us out at this point. So thank you very, very much. And it was wonderful meeting you.
Yeah, thank you all so much for